Hello, everyone, and welcome to our module on chronic heart failure. In another video, I talk in detail about acute heart failure, which refers to the situation when patients with heart failure develop acute symptoms like shortness of breath. They can have pulmonary edema and swollen ankles and elevated neck veins. And in this situation, treatment is aimed at symptom relief. So we use drugs, which I talk about in the acute heart failure video, like loop diuretics, nitroglycerin, inotropes. All of these things are aimed at making patients feel better. But once they feel better, they still have heart failure. It's a chronic condition. And so they need treatment long term after they're out of acute heart failure so that they don't develop worsening symptoms of heart failure in the future. And that's what we're going to focus on in this video, how to treat chronic heart failure. And in this situation, it matters a lot whether the patient has diastolic heart failure or systolic heart failure because the treatment of chronic heart failure is very different for the two subtypes. So we have lots of therapies that have proven benefit in chronic systolic heart failure. This includes many classes of drugs like the ones shown here, and we'll talk about these in this video. Also implantable devices like defibrillators and special types of pacemakers, and we'll also talk about these things later in this video. Unfortunately, we have no direct therapies that are beneficial for chronic diastolic heart failure. If you look at the American Heart Association guidelines for treating chronic diastolic heart failure, they recommend treating the patient's comorbidities aggressively, things like hypertension, diabetes, or AFib. If any of these are present, we need to treat them aggressively. But of course, this is something we would do anyway. This isn't really specific to diastolic heart failure. And the reality is that the mainstay of treating patients with chronic diastolic heart failure is simply monitoring them for a recurrence of their symptoms and sometimes using oral diuretics to keep them from accumulating fluid volume. But we really don't have a lot of therapies that directly target the heart and prevent diastolic heart failure from coming back in the long term. So in this video, what we're going to do is focus on all the drugs we use to treat chronic systolic heart failure. And what can be hard to get your mind around as a medical student is that when we're treating chronic systolic heart failure, we're not really treating any specific symptoms. Patients may actually feel good, their lungs may be free of pulmonary edema, but they have a depressed left ventricular ejection fraction. And lots of studies have shown us that this ejection fraction will get worse over time, and eventually the patient will develop symptoms again or die from heart failure, and we don't want that to happen. So all the treatments in chronic systolic heart failure are given based on clinical studies that have shown that they improve outcomes in patients. These drugs are not going to make patients feel any better immediately when they take them, but they are going to protect them over years from having their heart failure get worse. So understand that patients with chronic systolic heart failure all have a cardiomyopathy. They all have a depressed left ventricular ejection fraction, and they have a disease process of their left ventricle, and this gives them a persistently depressed LVEF. And when the LVEF is persistently depressed, there's chronic overactivation of two physiologic systems. One is the renin-angiotensin-aldosterone system, also called the RAS, and the other is the sympathetic nervous system, especially stimulation of beta-1 receptors in the heart. Because these things go on chronically, we believe this is what makes systolic heart failure get worse and worse and worse as years go by. So a lot of the drugs we use for chronic systolic heart failure disrupt these two systems because blocking their effects leads to a decrease in mortality and disease progression. So we'll start by talking about drugs used in chronic systolic heart failure that disrupt the renin-angiotensin system. I discussed this system in detail in videos in the renal section, but by way of brief review, angiotensin 1 is found in the body and converted by angiotensin converting enzyme into angiotensin 2. And angiotensin 2 has numerous effects in terms of renal and cardiac physiology. It does all the things shown on the slide here. And so the net result of activation of the renin-angiotensin system is all the things shown here. Salt and water retention goes up, preload to the left ventricle goes up, TPR goes up, and afterload on the left ventricle goes up. And it's believed that when this system is chronically overactive and these things are going on chronically, that's what makes heart failure worse for systolic heart failure patients. Eventually, their left ventricular ejection fraction gets worse and worse, caused in some part by chronic activation of this system here. So there are two drug classes we use in chronic systolic heart failure that disrupt this system. One is the ACE inhibitors, which inhibit this enzyme so that there will be less production of angiotensin 2, and the other are angiotensin receptor blockers, which directly block the effects of angiotensin 2 on its receptors. So the ACE inhibitor drugs used in systolic heart failure all end in pril. So they have names like captopril or enalapril or lisinopril or ramipril. And like I showed you on the last slide, these drugs inhibit the enzyme ACE and they block the conversion of angiotensin 1 to angiotensin 2. The angiotensin receptor blockers, or ARBs, all end in sartan, so they have names like candesartan, irbesartan, or valsartan. And as I showed you before, these directly block the angiotensin 2 receptor. And the reason we use these drugs in patients with chronic systolic heart failure is because both classes of drugs have numerous clinical studies showing that they reduce the mortality rate from chronic systolic heart failure and they reduce the frequency of hospitalizations for acute heart failure. So remember, we're not giving these drugs to patients to make them feel better in the short term. They're not going to feel any different when they take the medicine compared to when they don't. But if they take these drugs every day for years and years, their likelihood of having one of these two bad outcomes is substantially lower. And both of these RAS drug classes have similar side effects. They can both cause hyperkalemia because they decrease the effects of aldosterone, and they can both cause renal failure because they decrease the GFR. It's super high yield for your step 1 exam to know the hemodynamic effects of ACE inhibitors and ARBs. They're highly likely to ask you about this on your test. So remember that angiotensin 2 is a very powerful vasoconstrictor. So when you limit its effects, either by inhibiting ACE or by directly blocking the A2 receptors with ARBs, this is going to lead to vasodilation. So all the drugs that inhibit the RAS system for chronic systolic heart failure, the ACE inhibitors and the ARBs, they all function as vasodilators, and therefore they generate a fall in the total peripheral resistance. This can also reduce the blood pressure, so these drugs lower the blood pressure. The fall in TPR and blood pressure represents a fall in afterload on the left ventricle, so these drugs generate a small rise in the cardiac output, and that's one of many reasons that they're beneficial in chronic systolic heart failure. When the cardiac output goes up, more blood is pumped out of the left ventricle with each cardiac cycle, so at the end of diastole, there's less blood in the left ventricular chamber. Therefore, these drugs cause a small decrease in the left ventricular end diastolic pressure. And so I've summarized these hemodynamic effects at the bottom of the slide here. The ACE inhibitors and the ARBs lower blood pressure, they slightly raise the cardiac output, they're vasodilators, so they lower the TPR, and they're going to decrease the LVEDP. ACE inhibitors have a couple of unique side effects that you should be aware of. These are all related to the fact that ACE inhibitors increase levels of bradykinin in the body, and I'll talk more about bradykinin in just a second. But because ACE inhibitors raise bradykinin levels, they can cause a dry cough. Bradykinin can trigger a dry cough in about 10% of patients who take ACE inhibitors. The dry cough is much less common with ARBs, so usually if a patient develops this side effect of an ACE inhibitor, they are switched to an ARB. And then angioedema refers to swelling of the face and tongue, and it can be life-threatening because it can close off the airway. This is a picture of a girl here with angioedema around her eye. And this is a rare but feared side effect of ACE inhibitors because it does occur in a small number of patients. So we talked earlier about how ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2. Well, it turns out they also block the breakdown of bradykinin, which is a naturally occurring substance, into inactive metabolites. So when this gets blocked by ACE inhibitors, levels of bradykinin go up, and in some individuals, this triggers the cough and vasodilation that can be seen as adverse effects of these drugs. Okay, now let's talk about beta blockers. So if you could find a textbook on heart failure from the 1970s or 1980s, that textbook would say that beta blockers are contraindicated in systolic heart failure. And that's because these drugs are negative inotropes, which reduce contractility and lower the cardiac output. And that was thought to be bad in chronic systolic heart failure. It turns out, however, that multiple large randomized trials have shown that if patients with chronic systolic heart failure take a beta blocker over the long term, meaning for years and years, they are less likely to have bad outcomes. And this is believed to be because these drugs block the sympathetic nervous system from overstimulating the heart. And that's thought to be one of the reasons why the heart gets worse and worse over time in patients who have systolic heart failure. We only use beta blockers in chronic systolic heart failure. We don't use these drugs in acute heart failure when patients are symptomatic with shortness of breath and pulmonary edema. And that's because in the short term, they'll worsen the cardiac output and the symptoms can get worse. We only start the beta blocker after the patient is feeling better and they're no longer in pulmonary edema and acute heart failure. that's when you start the beta blocker and the patient takes it for the long term. There are 3 specific beta blockers that have been studied and found to be beneficial in chronic systolic heart failure. Those drugs are metoprolol, which is a beta-1 blocker, carvedilol, which is a beta-1, beta-2, and alpha-1 blocker, and also bisoprolol, which is a beta-1 blocker. All 3 of these beta blockers have been studied in large randomized trials of patients with systolic heart failure, and they've been shown to reduce the risk of mortality from systolic heart failure and the risk of being hospitalized for heart failure. Let's talk about the hemodynamic effects of taking a beta blocker. This is high yield to know for your step 1 exam. So beta blockers will lower the heart rate and decrease contractility, and this is going to lead to a slight fall in the cardiac output. Most patients with systolic heart failure can tolerate this, and so we give them this drug despite the decrease in cardiac output because over the long term, the drug is beneficial. Because the cardiac output falls, these drugs reduce blood pressure. You may know they're also used as antihypertensive drugs. And then because the heart rate slows down, there's more time for the left ventricle to fill. So beta blockers actually cause a slight rise in the left ventricular end diastolic pressure. And then finally, because these drugs reduce the cardiac output and the blood pressure, they activate the sympathetic nervous system, and that can increase the total peripheral resistance. So summarized at the bottom of the slide here are all the hemodynamic changes you would expect when you start a patient on a beta blocker. Okay, next let's talk about drugs that block the effects of the hormone aldosterone. So angiotensin II, as part of the RAS, can stimulate the adrenal gland to secrete aldosterone, and in turn, aldosterone promotes renal sodium and chloride retention. So this increases fluid volume in the body, and that can be bad in heart failure. So aldosterone-blocking drugs like spironolactone and eplerenone, they block the effects of aldosterone on the kidneys so that the kidneys do not hang on to sodium and water. So spironolactone and eplerenone are the 2 major aldosterone antagonist drugs used in chronic systolic heart failure. This class of drugs is also called potassium-sparing diuretics because they are diuretics that do not waste potassium in the urine. They're also called mineralocorticoid receptor antagonists, or MRAs. But both of these drugs block the effects of aldosterone, which is a mineralocorticoid, on the kidneys, and they cause a diuresis. Basically, they block the reabsorption of sodium and water, so they cause more sodium and water excretion. You can think of them as diuretics. They're called potassium-sparing diuretics because they spare potassium, like I said, so they do not increase potassium excretion, which is what other diuretics, especially loop diuretics, do. So that's why they're called potassium-sparing. And for this reason, hyperkalemia is a side effect of these drugs, and this is unusual for a diuretic. For most diuretics, hypokalemia is the side effect, but not for these drugs. And just like beta blockers and ACE inhibitors and angiotensin receptor blockers, there are many large randomized trials that have shown that patients who have chronic systolic heart failure who take one of these drugs will have a reduced mortality rate and a reduced hospitalization rate for heart failure. The hemodynamic effects of mineralocorticoid receptor antagonists are pretty straightforward. These drugs cause a diuresis, so they reduce the circulating blood volume. That leads to a fall in cardiac output and a fall in blood pressure. Because the cardiac output and blood pressure fall, the sympathetic nervous system is activated, and there's a rise in the total peripheral resistance. And then finally, because you're losing circulating volume, you get a fall in the LVEDP. So all of these changes are summarized at the bottom of the slide here, and basically these are the same changes you would expect from any diuretic. All diuretics will cause these effects I've summarized at the bottom of the slide here. If you look at the bottom of the screen, I've shown the chemical structure of testosterone here, and you can see that it is similar to the structure of spironolactone. And if you know that, it's an easy way to remember that some of the side effects of spironolactone are related to the fact that it blocks testosterone effects. And this can be a problem, especially in men, because it often causes gynecomastia. About 10% of men who take spironolactone develop gynecomastia. And that's the benefit of eplerenone. It was developed because it has similar effects on the kidneys to spironolactone, but it does not cause gynecomastia. And then at the bottom of the screen, you can also see that progesterone is similar to spironolactone. In fact, spironolactone is a derivative of progesterone. And so if you know this, it's an easy way to remember that spironolactone can activate progesterone receptors in women, and this can cause amenorrhea as a side effect if it's given to women who are premenopausal. Okay, next let's talk about sacubitril, which is a drug that is a neprilysin inhibitor. So neprilysin is an enzyme that degrades atrial natriuretic peptide and brain natriuretic peptide. So when you inhibit neprilysin, you get higher levels of ANP and BNP. I talk about ANP and BNP in detail in the video on heart failure basics, but by way of review, these two hormones antagonize the RAS system. And so when you give sacubitril and you make their levels very high, this will actually blunt the RAS system, similar to the effects that you get from giving ACE inhibitors or angiotensin receptor blockers. So sacubitril will lead to vasodilation by antagonizing the RAS system. It also leads to natriuresis, which is sodium excretion, and diuresis, which is water excretion. Also, the high levels of ANP and BNP caused by sacubitril will block sympathetic nervous system effects and reduce sympathetic tone on the body. Sacubitril is never given alone. It's always given as a combination drug called Entresto. Entresto is an oral drug that combines sacubitril with the angiotensin receptor blocker valsartan. And the idea behind this combo drug is that the valsartan will block the effects of the RAS, the sacubitril will increase ANP and BNP, which will further block the effects of the RAS, and overall you'll get a great diminishment of RAS activity. And in large randomized trials, Entresto has been shown to lower mortality from chronic systolic heart failure and lower the hospitalization rate. And that's why it's given together with beta blockers and other drugs to patients who have chronic systolic heart failure. In terms of side effects, sacubitril has only been studied in combination with valsartan. And when you give a neprilysin inhibitor like sacubitril together with valsartan, most of the side effects you see are similar to those you would expect for ARBs alone. So you can get things like hypotension and hyperkalemia, and these are side effects we talked about earlier for ARBs. The feared side effect of Entresto, the combination drug of sacubitril and valsartan, is angioedema. I talked about this earlier in respect to ACE inhibitors, but this can also happen with Entresto, and that's because neprilysin also degrades bradykinin just like ACE inhibitors, and so it can cause angioedema. And so a special note here that's high yield to know for your boards is you cannot give sacubitril together with an ACE inhibitor. In fact, if a patient is on an ACE inhibitor and you want to switch them to Entresto, which contains sacubitril, you have to wash out the ACE inhibitor for 48 hours before you start the sacubitril drug. Okay, let's talk about ivabradine. This is a drug that is sometimes used in chronic systolic heart failure, although it's used much less frequently than the other drugs we've been talking about up to this point. So ivabradine is a selective sinus node inhibitor, and the idea behind ivabradine is that studies showed that systolic heart failure patients who had an elevated heart rate had a worse prognosis. So this drug was developed to slow the heart rate by inhibiting the sinus node without blocking beta receptors, so there would be no decrease in contractility of the left ventricle. The way ivabradine works is it inhibits the SA node pacemaker funny current, which I talk about in detail in the videos on action potentials. And so when you inhibit this funny current, you get a slowing of the heart rate, but there's no effect on contractility of the left ventricle. This drug is reserved for patients who are already on max dose beta blocker, but their heart rate is elevated, and so it really isn't used that commonly. But it does have some limited evidence from randomized trials that it decreases mortality and hospitalizations in patients with chronic systolic heart failure who are already maxed out on a beta blocker. All right, the final class of drugs that has benefit in chronic systolic heart failure are the SGLT2 inhibitors. These are drugs like empagliflozin or dapagliflozin. They inhibit SGLT2, which is a pump found in the proximal tubule. It reabsorbs sodium together with a lot of your filtered glucose. So when you block this pump with one of these drugs, sodium goes out in the urine, which causes a mild diuresis, and also glucose goes out in the urine, which lowers the serum glucose. And that's why these drugs can be beneficial in patients who have diabetes, in addition to patients with chronic systolic heart failure. The adverse effects are mostly related to the effect that these drugs cause glucose to be present in the urine at high amounts. So in women, this can cause vulvovaginal candidiasis, and this can potentially lead to UTIs as well. These are oral drugs, and as I said, they cause a mild diuresis, so they reduce the preload, and they have similar hemodynamic effects to other diuretic-type drugs. Nobody's really sure exactly why these drugs are beneficial in chronic systolic heart failure, but the randomized trials have been compelling and shown that SGLT2 inhibitors carry a substantially reduced risk of mortality and hospitalization when given to patients with chronic systolic heart failure. And now they're being used in patients with and without diabetes. Obviously, they're beneficial in diabetes because they lower the glucose, but they also have benefits in patients who have chronic systolic heart failure without diabetes. So in patients with chronic systolic heart failure, you will hear the term guideline-directed medical therapy or GDMT used. This refers to using all of these drugs here to treat the patient's cardiomyopathy and prevent their left ventricle from getting worse over years and years. All these drugs have been shown in randomized trials to reduce mortality and/or hospitalizations from heart failure, and they're the backbone of treating patients who have chronic cardiomyopathy and systolic heart failure. Remember, none of these drugs are going to make the patient feel any better necessarily. Often patients feel the same on or off the drugs, but these drugs protect their left ventricle from getting worse over time, and that's why chronic systolic heart failure, which used to be fatal within years, is now a chronic disorder that patients can live with for decades and decades. Okay, beyond the drugs for chronic systolic heart failure, there are two devices that can be used to keep patients from dying from heart failure. One is called an implantable cardiac defibrillator, or an ICD. This is a small device that's placed under the skin in the chest with a wire that connects to the heart, and it detects arrhythmias like ventricular tachycardia, which is shown here. And if it identifies a life-threatening arrhythmia, it delivers a shock to convert the patient back to sinus rhythm. And the idea behind ICDs is that the annual risk of sudden cardiac death in patients with chronic systolic heart failure is higher than 20% in some studies, and most of those deaths are due to ventricular tachycardia, the arrhythmia shown here, and this arrhythmia can be aborted with an ICD. This is what an ICD looks like on the slide here. It can fit in the palm of your hand, and in appropriate patients with systolic heart failure, it's been shown to improve mortality. Placing the device does carry some risk. It requires a minor surgical procedure to place it. There's a risk of bleeding or infection. And then one of the main risks is inappropriate shocks. So sometimes the device cannot distinguish ventricular tachycardia from other benign rhythms like sinus tachycardia, and it could deliver an inappropriate shock. Okay, so ICDs are one medical device that's surgically implanted that we use in treating patients with chronic systolic heart failure. But there is another type of device, totally different from an ICD, that we also surgically implant sometimes for chronic systolic heart failure. And that device is called a biventricular pacemaker. It also goes by the name of a BiV pacer. It's also sometimes called cardiac resynchronization therapy, or CRT. To understand the idea behind a BiV pacer, let's look at these two echocardiograms on the screen here. If you look at the one on the left, this is the left ventricle here, this black part in the middle. These are the walls of the left ventricle here. And this person has a left bundle branch block, so their walls are contracting out of sync. You can see that when this wall's coming in, this wall's going out, and when this wall here comes in, this wall goes out. So because of the left bundle branch block, this person who has systolic heart failure has their left ventricle contracting out of sync, which makes the cardiac output worse. After you place the pacemaker, it forces the two walls to contract at the same time. And so hopefully you can appreciate that now they're coming in at the same time, and we're actually getting a more effective squeeze of the left ventricle. So this is the idea behind a biventricular pacemaker. It forces the walls of the left ventricle to contract synchronously. This is totally different from the other types of pacemakers for patients who have bradycardia and slow heart rates. Those do not work like this. This is a unique type of pacemaker used only in chronic systolic heart failure when patients have a left bundle branch block and are out of sync. Okay, so that's it for the treatment of chronic systolic heart failure. I'll finish with this one summary slide just so you can have it straight in your mind how we treat heart failure. So remember, when patients have acute heart failure and their lungs are full of fluid and their ankles are swollen, these patients don't get the treatments we're talking about in this video. They get treatments I talk about in the acute heart failure video, things like Lasix, which is a loop diuretic, or nitroglycerin, or inotropes. And we do this until they feel better and their lungs are clear and they're breathing better. At that point, they have chronic heart failure, and now the actions that we take depend on whether they have diastolic or systolic heart failure. For diastolic heart failure, there's really no specific therapy, but for systolic heart failure, meaning patients who have an ongoing cardiomyopathy and reduced ejection fraction, all the drugs talked about in this video, the ICD, the BiV pacer, these are all potential options that will improve the outcomes of these patients who have chronic systolic heart failure and who are out of the acute phase. And that concludes our video on chronic systolic heart failure.